Good morning, everyone. Welcome to Dr. Speak. We have Lou Lambie. Lou, can you have your video on, please?
Absolutely. Okay. Good morning, everybody, and welcome to our normally annual, although it's been a couple years, Dr. Speak Forum. It's hosted by the Lion's Eye Research Foundation of New Jersey, and we are able to pull this off every year with the cooperation of our friends and colleagues from the Rutgers Medical School. And, oh, look, Mel. Can you hear us, Mel?
I can hear you.
Outstanding. Mel, want to take over?
No, because I'm going to drop off again in 10 seconds anyway. So let's keep it moving and don't wait for me.
Okay, so we have some nice presentations for you this morning. And I'd like to introduce Dr. Zarbin, who will introduce the program and tell us a little bit about the Institute, and then introduce our first speaker. Thank you.
Good morning, everybody. I'm talking to you from my office at the Rutgers, New Jersey Medical School. I just saw a post-op this morning. I want to, first of all, thank you all for the support that you've provided to us over the years, millions of dollars of support. And we use the money to support our research mission. In fact, it supports a variety of research undertakings. Faculty members receive grants to support the research, and that includes me. I receive support for research also. You've also provided support by acquiring equipment for our use for clinical work. For example, you helped us acquire the handheld OCT device, which allows us to image the retina with 3-micron resolution. But it's a handheld OCT, which means we can use it in the operating room. Just used it in the operating room this week when I was operating on an infant that had a hemorrhage blocking the central retina, and I had to make a very delicate incision in a membrane overlying the retina, and this instrument is very, very helpful for me for that. So we have some outstanding speakers this morning. Dr. Roger Turbin, Chief of the Trauma Service, also a neuro-ophthalmologist and orbital surgeon, is going to speak first. Then Dr. Rudy Wagner, probably the most experienced strabismus pediatric ophthalmologist surgeon in New Jersey, who's the Chief of the Ophthalmology Service, the Pediatric Ophthalmology and Strabismus Service here at the medical school. And then Albert Corey, who is the Chief of the Glaucoma Service and also the Director of the Residency Training Program. Dr. Corey directs a training program which is unique in the state. It is the only ophthalmology residency training program based in the state of New Jersey. And the last time I did the analysis, about 25% of the ophthalmologists practicing in New Jersey have had some affiliation with this Department of Ophthalmology or the New Jersey Medical School. So his work has a tremendous impact on the quality of eye care that's rendered throughout the state. What I would like to do is just give you a brief overview of the department during the past year. And it wants me to upload a file, but what I want to do is share my screen. So give me a second here.
Doctor is already shared.
It's shared. Okay, so I can't see my slide, so that's the problem.
You unshared it. It was shared.
I unshared it. Now I'm going to share it again. So my computer. And do I have to upload the file again?
No, it will be already there.
Okay. So if I go to this, can you see it? No. I'm sorry, but I don't see my. Should I press share?
Yeah, share screen. Just
share screen. There we go. Beautiful. Share screen. And I will do this. There we go. Great. Can you see it now? Yeah. So this is the state. And I guess to advance, I don't see an advance.
Just go on the screen, and you would have the next button.
Go on the screen then, like this. Can you see it now?
Yeah. If you go into the slide, the presentation mode.
Yes.
So right now you are not on a presentation mode. You are.
I actually, on my screen, I am. I mean, on my computer, I am. But let me look. What you may be telling me is that I'm not in the presentation mode in the computer. And I don't see where to go to make that happen. Oh, maybe this will do it. Does this do it?
No, you can just go to the next screen. Next slide. On the screen, that would be good enough.
See, that's the thing, is that I can't do that. I don't see it's not allowing me to do that.
You can just like sort of minimize your browser and go to your slide.
Okay, I'll do that. Can you see this?
We can see your screen. We can see the PowerPoint, but it is not in a presentation mode. It is in the edit mode.
Unfortunately, I'm now putting it in the presentation mode, and it's not. Let me just look. Is this helping at all? No. Hold on. I'm going to try one other thing. Does this help at all?
No, it is not changing anything, doctor.
Okay. So can you see this?
Yeah, now we can see it. Yeah.
Okay. So this slide, pardon me?
We can see a graph.
Great. That's exactly what I'm showing. Sure. So the first thing I thought I would mention is the impact of COVID on the department. And the line that I think you should follow, since I can't show you all the animations with this way, is the blue line. And this shows what the outpatient volume was like before COVID. And when you see this big dip, that's April of 2020. And you can see that after the spring of 2020, the outpatient volume gradually increased, but it actually didn't get back to normal until literally a year later, April of 2021. So there are many downstream consequences of the decrease in patient volume from the COVID. First of all, that means that there were patients who were not accessing the eye care. We were here available to provide it 24/7. But unfortunately, because people were afraid to come in, there were people that actually lost vision because they weren't getting their treatments on a regular basis. Another consequence of it is practical. Decreased clinical volume means decreased revenue. And of course, this was a nationwide problem. The good news is that we're really quite busy once again. In fact, maybe we're busier than we used to be. So I would say that at the moment, as you'll see, the department is actually doing pretty well from a clinical volume standpoint. This slide shows you something important about our resident training program. Naturally, the most important thing that we teach the residents is clinical skills. And clinical skills includes how to diagnose diseases, how to do surgery, and maybe most importantly, how to be a doctor, which is something that maybe we all keep learning how to do for about 30 or 35 years. But the beginning of learning of how to be a doctor really, I think, starts in earnest in residency training. Everyone knows what I just said. What people may not know about is the importance of intellectual development as a lifelong learner, as a physician. And lifelong learning begins with being a good student. So this graph this table shows you their performance on this national test that all the ophthalmology residents take. And you can see that in 2021, 100% of the residents, that's all 15, were in the top half of the scoring of the US, and actually 60% of them were in the top third. So that doesn't happen by accident. The residents are working very hard and they're studying very hard. Another aspect of resident training, which I think would generally not be recognized by the lay public, is how to establish the habits of being a lifelong learner. And that actually comes from writing and publishing papers, because the processes that are involved in writing papers and publishing papers are the processes that teach you how to be a careful reader of other people's work. Now, you might think that the scientific literature, because it's reviewed by peers, it doesn't require critical analysis. If you're a reader, you might think if every article in the peer-reviewed literature you read has been vetted by other professionals, that you can take it as the truth. Actually, that isn't the truth. And I could give a whole lecture on errors that appear published in very highly respected journals. So each of us as physicians needs to assume the responsibility for being a critical reader of the scientific literature. And here you can see that the residents are quite productive intellectually in terms of producing their own research with faculty members. And these are things that get presented at national and international meetings. And of course, it's hard for the residents to be taught about how to be intellectually productive if the faculty isn't intellectually productive themselves, and they are. As you can see, that the faculty in 2021 in the aggregate published 113 papers in the peer-reviewed literature. That's when you consider how busy the faculty members are clinically, that's really a very remarkable level of intellectual productivity. And that's exactly what you'd expect from people who are intellectual leaders in their field. We take care of everybody in this department, everyone in New Jersey. We take care of people that come here in limousines, because they're very rich. We take care of people that are in prison. We take care of people that don't have a place to sleep at night. We take care of the whole world. And you might think, given that we are a state institution and that we're located in Newark, that basically all our patients are coming from the Newark metropolitan area. And that is not true. And in fact, it's never been true. So I could go back literally 28 years, but I'm just showing you from 2010 to 2021. About half the patients that we see come from Essex County, and that means half of them come from everywhere else. So we're here to serve everyone in the state of New Jersey, which I know you all know. I just don't know if everyone in the state recognizes that, and therefore recognizes what a valuable resource this institution is to the state of New Jersey, and not simply to the citizens of the Newark metropolitan area. So that's my brief overview of the department. I want to thank you, each of you, again, for everything you've done to help us. I couldn't be more grateful, and everyone in the department shares that gratitude. You work behind the scenes. You work anonymously. We really respect and value your contributions, and we rely on them. So thank you for all you've done, and thank you for all that you are going to do. I'm happy to answer any questions, should there be any. There certainly don't need to be. And after each of the speakers, there'll be a brief time for questions, should you have any. We'll limit each presentation in total, the presentation and the questions, to no more than 30 minutes, though, out of respect for your time and that of the speakers. So I'm going to stop sharing. And I'll wait a minute. I don't expect, frankly, there to be any questions, but I'll wait a minute just in case there are. And then ask Dr. Turbin to begin. Okay, I don't think there'll be any questions, Mahesh. So if it's okay with you, I think we should start with Dr. Turbin.
Dr. Turbin, you are on the broadcast.
Thank you. And can you see my screen?
No.
Not yet.
Now I can.
Okay, great. Full screen?
It looks.
Okay. Thank you. So I am Roger Turbin, and I wanted to thank Lyons and Dr. Zarbin for this opportunity to run through a survey of what we have been doing over the last few years in the department, in the divisions of neuro-ophthalmology, trauma, and orbital surgery. And this is going to be a tour de force. I've selected some photographs that may be shocking, and we'll talk a little bit about that. But I needed to keep you up and not put you to sleep. So what is new in our world? And I actually selected this logo because it's out of focus, and it highlighted to me just how important. I find this immensely disturbing, looking at this little photograph that is out of focus. And then one realizes our patients and how just having vision slightly off becomes such an important, aspect and focus of their life. And some of the things I'm going to show you force the patients to have vision that is significantly different than this little blur. And let's talk a little bit about it. So some of the work that we do, is obviously in state, some is out of state. And I just wanted to highlight my team of doctors, and we have Dr. Rubinstein, who's a resident, and Laura Papsiak and Barbara Sandberg for some mission work that we've been doing down in Grenada. And unfortunately, this is the type of thing that dropped out during COVID. And our last trip was in 2019. The last time I was down there, we were able to establish a stroke program down in Grenada, the first time that they have had the ability to begin to care for strokes. And this picture on the right is not an advertisement for marijuana in New Jersey. This was a happy farmer bringing in, Grenada is the island of spice, and those are bags of allspice and bay leaves and cinnamon, rewarding us for our work. And that was just incredible to help the people of Grenada. Well, I was looking at the effects of the eye, or artist impressions of the eye. And I'm going to emphasize a contrast between the beautiful and the grotesque, and how new instrumentation and new technology allows us to move from the grotesque back to the potentially beautiful. And I selected these photos because they're original. And this is actually a friend of mine's work. And interestingly, look at how this is Brian Griffin, and how he concentrates. There's this aspect of the artist concentrating on the eye. And look at how disturbing the double vision he created of himself, a disturbed image of himself as a child, and his work being shown at the Fringe Festival in Cincinnati next month, of what he calls a painted collage, and the emphasis on anatomical components of the body. And this is actually some work from my friend's daughter out in San Francisco, who was happy when I was out at one of the Academy meetings to run by to see if this photo that she developed of the eye was accurate, and we worked on it together. And this is a picture at age 12 that she created, also with emphasis on the eye. And these are not my photos, but they're photographs that I took from the internet of the grotesque in art. But these photos, they're horrible. They're horrible. These pictures, they're horrible. But there was a talent, and there's some beauty underlying the knowledge of anatomy and the skill of the artist reproduced here. And so let's take a look at what we have. So grotesque. Newark, we have the never-ending trauma. I call it the knife and gun club. And this young man, poor young man, was a subject of the knife and gun club. But we work with him, and he required a series of surgeries and repair, and this is his midway through the repair, and this was ultimately more revised somewhat down the line, and this is him today. And we went from the grotesque with just meatball surgery to the light touch of an artist with one of the oculists who does prosthetics. And this is him a few weeks ago with the reconstruction of the eyelid. And that's a new eye and a new shell. And this is some of the work that I do, that Dr. Langer does, and the rest of the team in the department. And more of the knife and gun club. This is, last month. And this was an 18-year-old boy who took a gunshot wound across, the temple, lost his left eye, and the fragment, forensic fragment that we removed from the right eye. And I'd hazard to say that this wasn't in the news. Had it happened in my community where I live, it'd be all over the news. But we're working with this type of thing and the inequities. Every day we see this, and we go in, we're called in, the faculty and residents are called in at 2, 3, 4 in the morning, and it's, oh my gosh, it's going to be another all-nighter. But when we come out, there's a satisfaction that we all get of being able to say, we put this patient back together, and it's very rewarding. So I wanted to turn to some of the developments of technology and how they're being used. And this system actually is a buying opportunity for the Lions for Rutgers here. So this is work that I'm doing at another institution. It's piloted work, and it has to do with a specific type of system that allows us to use intraoperative navigation. And we have some of these components at University Hospital. But what this system is about, you can notice on the left, a patient undergoing surgery, head is rigidly fixed with pins to a frame. And then a broadcasting agent is attached to that frame in a rigid way. And there is a receiver on the right side of your screen. And one then takes, this is a colleague at JFK, Dr. Steineke, in neurosurgery. One takes a wand and runs it over particular areas on the face. And that's transposed to CAT scan and MRI images that are amalgamated. And then during surgery, we place CAT scans and MRIs and correlate where an instrument is touching on the face to produce CT and MRI images during surgery, which is extremely helpful in my orbital cases, Dr. Langer's orbital cases, and especially combined neurosurgical ENT and orbital cases, highlighting the teamwork that we do here at Newark and in our other institutions. This is pretty standard stuff at an academic institution. However, there's a new component that we've begun to use, and this is actually relatively privileged information that it's not widely available, and we're just beginning to use it. So what the problem with the previous system is the coarsity of having to stop what you're doing, bringing in instruments, and looking at three-dimensional views, stopping what you're doing. What this system, which is called the surgical theater, and I'm going to show some images of this, allows us to do is take the images using a specialized software and do 3D imaging and plan. And then as you're operating, the imaging focuses on the plane of focus of the camera. That's what's special. So we're operating through a microscope, and what we're looking at then becomes focused at the level of focus of the camera, so that the microscope, where it's focused in the surgical field, is driving three-dimensional CT and MRI images on a screen. And then there is almost a holographic image that it can be superimposed in the binoculars of the microscope, so we can actually see what's on the MRI or CT that we've preoperatively planned. Let me give you a demonstration here. And so this is a patient, one of my patients, that one of the first cases that we did. And so preoperatively, we have defined what the tumor is on the left, and there's the mass, and we can lay out important structures that you can't see when you're operating, and that important structure is the optic nerve. We don't want to hit that. And here we have an amalgamation of CT and MRI. And now to the grotesque. Notice we're operating, we're coming in from the brain. There are 4 hands in here. These are my hands and Dr. Steineke's hands. There's 4 hands in here. You don't see the tumor, but now this is what we're projecting through the microscope, so that that hologram gives us some additional information about where critical structures are as we move down. And it allows us to proceed with a degree of safety that is just incredible. And it speeds up the surgery, shortens surgical times, and it just gives the operating surgeon an incredible perspective. So we're looking at the tumor, and we can look beyond structures. That blue line is the exact line of focus of the microscope. And so instead of stopping what we're doing, we're seeing this in real time. And that is a 3-dimensional image of the projected tumor. Early in the planning, at the beginning of the case, we'll outline what we feel is important. And I think I can move through this one. And we're going to go a little bit more in a second case here to a little bit more about how this helps us at the beginning of the case. And this is a patient who's got multifocal tumors, and we can outline what the tumors are. And this changed at the beginning of the case our ability to design the surgery and the approach. So we can actually fly through the patient's head and brain, create an opening. And this allowed us to design the opening and the craniotomy to get to the tumor, because these tumors are surrounding such important critical structures. You see the large tumor there with the optic nerve and the chiasm running through it. So imagine operating in Play-Doh and trying to take out a piece, try to remove the Play-Doh with a piece of spaghetti running through it and not knowing where that next step is going to get you. That's what this instrumentation does. It allows you to see what's beyond what you can see. And it's just an incredible tool. So it's a purchasing opportunity, I would say, because I'd love to have one here, as well as our Department of Neurosurgery here. And so we've outlined the 3-dimensional structure of the tumor. These are very privileged pictures. You're looking at brain there, and you're seeing what we see. And this 3D hologram is showing what we need to be seeing and what we need to get at. And that's a very privileged picture. That's the optic nerve. That carries vision. That very few people in the world have ever seen anything like that. You're looking down at the optic nerve, and the tumor has actually been removed. So I think I've made my point with that. The grotesque. I wanted to emphasize the the opportunities that we have in the artwork that we develop. This actually is a publication that came from an experience, a shared experience that we developed here in patients with very, very severe infections, and ultimately with eye removal. And it presents the opportunity where one is taking out tissue and requires an implant, but there is some danger of placing an implant into infected tissue. So I actually developed the idea of creating an implant from drug-eluting material. This is called Palicose. It's the brand product. And we make different size implants, measure them out, and place them within an infected tissue bed. And one of my patients that I performed this procedure with the secondary procedure, had traveled down to Bascom Palmer in Miami, and they were amazed that we were doing this here, and reached out to me and to write a paper, and that led to this particular case report recently with myself and Dr. Johnson, who's the other lead author. And this was actually the patient. These are from the paper, so they are public, but it shows the removal of an eye, the primary initial placement of that drug-eluting stent in view C, and then removing it. The removal was done down in Miami, leaving a non-infected bed that secondarily allowed a beautiful implant, the beauty in the surgery from the grotesque in slide E. So I thought I'd move on away from some of the grotesque to some of important work that's been going on in the department and some of the publications associated with it. You may have seen the drug Tepezza or teprotumumab now advertised on TV. And this is a game-changing medication in Graves' disease, which is deforming, going back to the grotesque, visual loss causing Graves' disease. Barbara Bush had Graves' disease, and the progression of exophthalmos, the eyes sticking out, horrible orbital congestion, deformity. Teprotumumab is a game-changing medication. It's an injectable medication that's given over 6 months. And we had the opportunity here to participate in an expanded access use program, a research study that recently published these results. However, the medication is extremely expensive, and we're seeing payouts from insurance companies between $250,000 and $450,000 for a course of this, which brings up a development opportunity to create competing drugs, which we're participating in. And we had the opportunity to use the medication in some atypical forms of the disease associated with visual loss, which results in publications. And some examples again of going from the grotesque to the beautiful, if one may say, the beautiful results. And this is a patient in slide A with horrible, unresponsive orbital congestion. And if one looks in slide D and slide F, images D and F, massive enlargement of the extraocular muscles, and the progression and stability through slide B and C after the use of teprotumumab. And this is one of the published patients. And notice the difference in the eye muscle size between the MRI in image D and the CT in image E, and the coronals of the MRI in image F and the CT in slide G. What you're seeing is the muscles, massive shrinkage of those muscles. It's just a game-changing medication that we have is completely altered the course of the treatment of Graves' disease. And this all occurred actually during COVID over the last couple of years. In fact, this medication was initially pulled from the market because the drug company had to change its focus to the creation of the COVID viruses. And it was allowed to recommence generating the teprotumumab drug, and it's now back and available. And I wanted to highlight that we actually just had our study trial initiation visit on Friday, and this is public information, of a competing drug. I can't talk too much specifically, but another currently intravenous drug that is it attacks the IGF-1 receptor and works in a similar fashion to teprotumumab. And we're about to begin to enroll our first patients in phase 1 and phase 2. So this is really, really exciting stuff. And hopefully some competition in the market will drive down prices. And last but not least, I wanted to also highlight some of the future work that's coming. This is just our initiation, our notice of approval for some work that I'm doing, that Dr. Froman and I are working together with, looking at unusual forms of optic neuritis, and a retrospective study that will help us learn about some of the when we should be using new forms of treatment for some of the atypical forms of optic neuritis. So with that, I believe I am finished, and I guess I can hold for a few questions. And I believe I've stopped screen share.
Yes, doctor, there is no screen share.
And if there are any questions, I'll just hold for 10 seconds and okay.
Dr. Turbin, you are on the screen.
Yes. I'm sorry. Mahesh, did you want me to say something?
Yeah, you want to get the next doctor in.
Yes. Well, first, I wanted to thank Dr. Turbin. That's a fantastic presentation. I learned a lot from it. And thank you for doing such outstanding work, Roger. Really awesome.
Dr. Zarbin, may I interrupt?
Yeah, of course.
There was one question at the very end, right before we said that's it. I'm going to show it. What are the long-term implications for implants?
Can you
Roger,
hear me?
you might want to clarify what you mean by an implant so that no one is confused about whether that thing works as a seeing organ or not. I was wondering about that.
Can you hear me?
Yes.
So the implant, there are a variety of different implants. The implants that I presented to you are what are called enucleation shells, which represent a prosthetic to be placed after the removal of the eye, or potentially on top of a non-seeing eye. It would be the equivalent if one had a tooth removed. One would have a surgical implant, maybe a stem put into the bone of your jaw, and then there's a secondary component of the functional tooth that goes on top of it, which is not a surgical procedure. You would go to, the type of dentist that works with it. We are putting in a ball that creates space and allows for some movement of an artificial shell, and the shells are non-surgical component. They're essentially the cosmetic component, but unfortunately at this point they don't see, as what Dr. Zarbin was asking. But the goal is to place an implant that will last a lifetime without revisions from infection, with limited cleaning, a few times a year in terms of the shell. The surgical component, though, stays, and the shell can be taken in and out and cleaned. The grotesque that I showed and the drug-eluting component is a ball that's used as a temporary spacer, and at the same time as eluting antibiotics so it doesn't become infected. That has to be removed because it'll ultimately be dissolved. And so that creates a two-step or a three-step procedure where one is implanting the implant, which is helping to treat an infected socket, coupled with oral or intravenous antibiotics. And then that implant, that drug-eluting implant, is removed, replaced with a standard ball implant. And then the prosthetic shell, which gives that cosmetic appearance, is created non-surgically after that. I hope, and those are designed to last, for a lifetime.
Yeah, so it's what maybe colloquially would be called a glass eye, as that shell, and so what Dr. Turbin's doing for the patient, which is really important, is creating a more normal cosmetic appearance. But it's not a sight restoring procedure when you put that implant in, just to be clear about that. Okay. Can the same instruments? We're not dentists, so we shouldn't. That question we're really not qualified to answer. Sorry about that. Well, very good. So let me introduce the next speaker, Dr. Rudy Wagner.
Okay, thank you, Marco. Thanks for the putting this together. I have to say that having heard Roger's talk there, it was worthwhile for me to do this just for that, because I'm learning something that I haven't seen or haven't witnessed. I've seen a lot of optic nerve tumors on scans, and but I've never seen a picture that he showed like that actually can show you the extent of the tumor and its relationship to the surrounding tissue, which is really the difficult part in managing these patients. So to do that. The other thing it's reminded me of is that, just the trauma that we see, and we do see quite a lot, and Roger did a great job showing that, doesn't spare children. So we do get children with the same kind of things. We've had, sad stories, kids with drive-by injuries from bullet wounds and things like that just occur, and we sometimes don't think about what we're really doing, and then when you see it all together like this, you say, wow, there are some impressive things that are going on that we try to do our best with, and I think our department does a great job. And the other thing this is all reminded me of is the coordination that goes between our department, and I'll talk a little bit about that when I go on with this. But I'd like to bring up the slides for my slides if you can, Mahesh, please. So, once again, thanks to the Lions for helping putting this together and for their support throughout the years. I've known many people for many, many years that have been involved with the Lions throughout the state, and always been so supportive of things that we have done and continue to do. Go to the next slide, please, Mahesh. So I want to concentrate a little bit on some of the clinical activities that we're doing. You can see the second one there is the thyroid ophthalmopathy, which is something that Roger had spoken about. These are the people with the protruding eyes that you're all familiar with, where they have hyperthyroidism or Graves' disease, and they also end up getting strabismus. And so there's an overlap in what we do. And part of the treatment that's giving now for it, which Dr. Turbin or Roger, really described, really has changed our management of strabismus in many cases, because a lot of these kids, a lot of these adults that have this thyroid ophthalmopathy also get double vision because of misalignment of their eyes. And this medication in many cases avoids the need for eye muscle surgery as they go along, because you can solve the problem medically, which was not possible to be done before. So it's prevented a lot of bad disease and a lot of double vision, and it's also helped in our management when we do need to do surgery. So that's another overlap in our department, because most of what we do is a lot of strabismus surgery. If you go to the next slide, please. For us, a lot of it's just clinical. How do we get from where we have a child with what's called esotropia or crossed eyes or strabismus or lazy eye, whatever you want to call it, on the one side of the slide to the other, where the eyes are in perfect alignment, and most of the time it does involve surgery. So a lot of our clinical focus remains the correction of eye movement disorders, eye muscle disorders, and this is what we pride ourselves of in the department. And we have, again, it's a coordinated effort. Many of these kids have retinal issues, and some have even thyroid and other problems that can cause eye muscle disorders. The term strabismus, by the way, just means any misalignment of the eyes related to the muscles. So if the eyes cross in, we call it esotropia. If they go out, we call it exotropia. And commonly people will describe it as a lazy eye when they come in. They'll say the eyes are just not working together. So we can fix these most of the time, and we've made a lot of progress in that. And a lot of our work over the years has been involved with trying to improve our results with this. We're pretty satisfied with what we can do, but we can always do better, and we're always looking for new ways to do things that will help in our management. Can you go to the next slide, please, Mahesh? Good. So this is, I think, kind of an important thing. I think almost everybody probably in this audience who's listening to this today has someone in their family who's nearsighted, has myopia. And one of the things that's come up in the past few years, a lot of this work originally came out from Asian countries, Singapore, Taiwan, China, where they were having issues with, they call it epidemic myopia. So many young children were nearsighted or becoming nearsighted as they as they had not been in the past. The numbers have increased dramatically over the past few years. Some people relate it to this computer and cell phone time and excess near activities with their eyes. We're not sure, but we know that has some effect. I mean, during the pandemic, when these people weren't coming in, and as Dr. Turbin pointed out with his data, when they started coming in, we had so many complaints of the parents of their kids being frustrated with their excess computer time, closing their eyes, dry eyes, symptomatic, don't want to continue with their schoolwork because they've been so had so many issues related to it. And we have found out that your eyes do become drier. There's less frequent blinking. There's a lot of things that can occur. The eyes can fatigue. Most of these things, fortunately, don't seem to be permanent, but they can cause. But it's recently and continues to be, and it's only going to be more because look, most of the if you're around young kids, you know that most of their education now does involve computer work, and these kind of tasks, all these devices. They use it recreationally too, besides for schoolwork. So they're on them quite a lot. So we don't know exactly what the long-term results are going to be of kids using these things so excessively, but there probably is some relationship to the progression of myopia, although we can't prove it 100%. Now, we do know that outdoor activities are important. If kids in the sunlight seem to be helpful and not in sort of reducing the progression of myopia to a certain extent. So we encourage, kids out there playing soccer or whatever activities they like outdoors as much as possible. It's not so easy depending on your area of the country that you live in or the seasons that you have, but it does make some sense. The interesting thing though is that you will hear people using atropine drops. Atropine are the drops that we use to dilate the pupils, or one of the drops that we use when we're doing our examinations, let's say. But you can slow the progression of myopia or nearsightedness by administering these low dose drops of atropine. And the low dose is important because it doesn't dilate the pupil and give you the light sensitivity or the blurred vision that you all get if you go to an ophthalmologist after an examination. So these low doses avoid some of those side effects, but they can perhaps help in the progression of reducing the progression of myopia. And it seems to be effective. And we're looking for more patients that it would be effective. There right now, there's no medication that you can prescribe that's approved specifically for this. So we have to use what's called off-label use of an already approved medication to do this. There are a couple of studies going on in the United States right now, which if the results come out the way it's expected, there'll be pharmaceutical companies manufacturing drops specifically for this. The advantage being that they won't have these side effects of stinging when they instill the drops and other things that will interfere with their use. So that's fascinating. It's interesting, and it affects a lot of people. I mean, if you look at these numbers, I'm talking about. I've been told that in the country of in Taiwan, in the country, 80% of the children in the country are on a low dose atropine drops for the progression to prevent the progression of myopia. So it gives you an idea of the numbers we're talking about of how widespread this is. And I often tell parents when they come in that, when this drop, if it becomes approved in the United States and shown to be totally effective or as effective as we expect, it'll be the top story on any news that you'll see that day, because it affects just so many people in the world and in the country. So those are some of the things that are going on now that can be, we can intervene with. If you go to the next slide, Mahesh, I'd appreciate it. Just another thing I want to talk about briefly is that there is, the human genome has been mapped. So we know every gene matches up on a chromosome for a particular segment of the chromosome that produces a particular gene that causes a disease or prevents a disease or causes a particular function in the body. So this has all been mapped out, and that's been opened up a new world of gene therapy, which can be useful in treating some of these diseases. So unfortunately, it takes time to match the gene with the correct treatment. There is one available now. It's this Vortigene, which is really the first gene therapy that we have available, and you can inject this behind the retina into the eye. If they have a particular genetic mutation, which is this RPE65 gene, which causes inherited retinal diseases, the injection of this medication into the eye can actually help repair this damaged visual cycle. And it can, by establishing a new protein production, it can interrupt this damaged cycle and can actually bring it back to a more normal functioning. So this is something that people have been asking us for years that have these inherited retinal diseases. Is there anything that we can do? Is there any treatment available? And for years, we'd say, well, vitamins might work and things like that. But now we're finding that there are potential treatments available. And here's one actual treatment. And I believe that there are many, many studies going on for looking at different segments of the chromosomes and the genes and seeing where they could interrupt in this. And it's interesting, I noted on here that the way it's delivered, when you inject it, the gene is delivered by injecting an adenovirus, the virus that causes conjunctivitis, it causes colds, that causes a lot of things. But you can control that aspect of it. And the reason you use the virus is because it allows the gene to be replicated by the virus, so that when you get it near where the cells where you want it to be, it can have its effect. It's similar, I guess, to the mechanism of the mRNA viruses that you're familiar, vaccines that you're familiar with now that they're using for COVID. So you're taking advantage of a live virus to do helpful work for creating helping with these diseases. So this is really fascinating. But go to the next slide, please. So Mahesh, the reason I'm really talking about it is because I wanted to thank the Lions again. Just 2 weeks ago, I was introduced to this device that Dr. Turbin mentioned, this OCT, which is optical coherence tomography, which is essentially just another way of imaging tissue. However, you're imaging actual more imaging the anatomy of the retina without having to go in there and take a biopsy of it to see what really the disease is. And the reason it's important to me is because it's very difficult. There are other ways to look at the retina. You can inject fluorescein dye, you can take imaging, pictures, other types of ultrasounds, but it's very difficult to obtain that information in children. And we often put off the testing because we can't get it done at a particular age. So this device that is now available is allowing us to actually use that on a small child. It's non-contact. It doesn't touch the eye. So you can take a picture, an image quickly. And this is a slide showing the actually what I would call a non-invasive biopsy of the retina. You're not really biopsying anything. It's just a picture. But it shows you the layers of the retina. This is the middle, that depression in the V in the middle. That's the center of the eye, the fovea. And surrounding it are the rods and cones, which you're all familiar with studying sometime along your life in biology or psychology, that that are necessary for the photoreceptors that are necessary for vision. So we see children that we can't explain why they don't see as well as they should, and it's very difficult to determine what's going on in some of these cases with the anatomy of the retina and how it's related. If they have an inherited retinal disease, or they have a development of the macula, the fovea, the center of the eye that's not normal. So with this particular device, you can image that area and get an idea what's going on. I'll give you an example. We have, I thought this the other day when we have this available, we have kids that are very nearsighted that we can get them glasses, but we can't quite get them as good as we think we should be able to. And I wonder if some of them would be able to see in the retina some abnormalities that might explain that by the use of having this device, because it'll be easier to use in young children. So that I'm very thankful for, and I can't wait to be able to use it in our patients, and we'll be using it soon. And as Dr. Zarbin said, he's already using it. And I talked about this gene therapy, and I think that all these things are coming together. The technology that Dr. Turbin mentioned for what he's doing, this type of technology is really the future of ophthalmology, and we're fortunate enough to be able to have some of this. And of course, the more we can get of it, the better off we're going to be, and the happier we're going to be, and the better it's going to be for our patients. And again, I can't thank the Lions enough for being involved in over the years. In this particular one, is a great advancement that I can see. Next slide, please, Mahesh. Anyway, 16N, the Lions clubs, a lot of everything happens is related to research. We know all about the Lions Eye Research Foundation or Fund, and that's greatly appreciated. And sometimes we still have cases where we need help at an individual person to individual child to help them out. And we had a case recently. Now, just the way our residency program works, so and Marco described this quite well. But we have, at the Eye Institute, we have our residents there. They rotate through a number of other places, and one of the places they rotate through is Jersey City Medical Center, where we have our same residents that work in Newark, go to this institution too, and provide eye care there. And we had a situation where we had a child come up from Guatemala that had a retinoblastoma, which is an eye tumor that he actually lost vision because of it, and they had to enucleate his eye. Fortunately, there was no spread of the cancer, but he needed a prosthesis. So you saw those pictures that Dr. Turbin showed you, Roger showed you, where they're either with an absent eye, and he called it grotesque, and it is grotesque. So you can imagine a child going to school, having to face other kids, which you know how they are, about having something unusual or different about you without having an eye. So that in itself, is a big problem. So fortunately, a group of the Lions from 16N up in the area and the Lions Eye Research Fund were able to help this boy to get a prosthetic eye, which really, I don't even have, it so happened so recently, I don't have pictures of it, but it is obviously going to make a major impact in his life. So again, it's just another way of helping, in which we're so thankful for that people are involved with this. One more slide, please. I think. Last thing, I take any questions. And I was thinking of when Roger was talking about going on these programs where we do some teaching or patient care in foreign countries. And the very first place I went to years ago was on one of these programs or missions, if you want to call it, was in Dhaka in Bangladesh. And of course, I wasn't, maybe I was a little bit surprised, but you can hardly read on my slide there, but it was the Lions Eye Hospital there. That's a picture of it in Bangladesh. And it shouldn't be surprising, because I guess the Lions have donated a great deal of time and effort to eye diseases, as you all are well aware. And it's an international organization, and you do see these things happening all over the world. And this was probably, to this day, this is the poorest place I've ever been in the world, in Bangladesh, that I saw. But I was impressed and happy to understand that they even had support of Lions and their own people in the country supporting the institution themselves and getting some other funding. So it's just a great organization. I think I'd be happy to take any questions on what I said. I just want to give you a flavor of some of the things that are going on, and I appreciate your interest in this. So I see a question there, can a long-term underactive thyroid hypothyroidism cause eye disease? Well, if it's underactive, it's it can. It's more likely to be show symptoms of you can get dry eye and symptoms like that, but it doesn't generally cause the proptosis and the things that we're talking about with the eye muscles. That's usually caused by Graves' disease or overactive thyroid. However, the timing of the disease is not always related to when it's at its most greatest activity. Like if you do the blood work looking for the activity, you might not find as much elevation of the test that you would expect to find if you had hyperthyroidism with the Graves' disease. That can already tone down, but they still are getting the signs and symptoms of the hyperthyroid. So it's an interesting phenomenon that we will say. Oh yeah, this is something I was going to mention too about the spot screener. You found a number of our clubs in the eye screenings using spot screener have found a rise in the number of students needing referrals post pandemic. Is there any guidance that could be given to students to improve their eye health? Yeah, there are more referrals coming in, and a lot of it's what I spoke about earlier. There is I don't have that with me here today, but there is a statement by the American Academy of Ophthalmology that talks about some of the measures you can undertake for these kids that are on this excessive computer use and the symptoms that they get with the dry eye and blurred vision and things like that. Most of it involves, there's something they call the 20-20-20 rule, which means that after 20 seconds, you should take 20 minutes, you should take a break, look away for 20 seconds so that you're not overusing your eyes, just take breaks here and there. There's things about the contrast of the screen. Some are easier for some kids to use than others. There's just a lot of common sense things, and most of them involve trying to take some breaks from the prolonged computer use. But there is a statement from the American Academy of Ophthalmology that outlines a number of measures that can be taken to help these kids. And there's access to anyone. It's aao.org, and if you look up, pediatric computer use, or even for adults for computer use, you'll find some statements on that. And thank you.
One of the things that I was struck by with the atropine drops is that they are low enough dose that they don't induce dilation of the pupil.
Yeah.
And that made me think that, is it possible that the drops are working at the level of the retina and not through an accommodative mechanism?
I think you're right, Marco. I think that it's not been totally determined. There's some theories about it, but yes, I think most people believe it is working at the level of the retina for that very reason. Mm-hmm. Because of they're not getting symptomatic, they're not getting the cycloplegia, and they're not getting the other side effects that you'd expect. And in fact, it seems like if you in the range of the original dosing recommendation was 0.01, but now they've started. Some people are saying go up to 0.05. I've had said some kids when you go to 0.05, they start to get little dilation, a little bit of photosensitivity, and they had to go back. But it does work. I mean, I compromised on a few where I went to 0.25, but I guess 0.25, yeah, 0.025, and it seemed to be effective, just as effective. So yes, it's undetermined, but there's something to that.
It's interesting because there's a big cholinergic network in the inner plexiform layer, muscarinic and nicotinic. And that's what made me think maybe it's actually working by modulating some kind of input to the ganglion cells, something.
I think it probably is.
Yeah. Well, Rudy, thank you extremely for everything. Dr. Wagner gives so much to the department. I wish we should probably have a special banner acknowledging him. Here's a question. Can't get on the chat, but has Graves' disease and double vision treating by Dr. Fruman. He's an excellent doctor. I'm sure he's giving you the best possible treatment. That's not a question, so I don't have an opportunity to refer to anybody. Let me, to stay on time though, I want to thank Dr. Wagner and also now introduce Dr. Khoury. As I mentioned before, he's the chief of the glaucoma service, and I'm looking forward to his talk.
Everyone, pleasure to be here. Can everyone see my slides? Because it takes over the screen.
No, we can't see the screen as yet.
Okay, hold on. Let me redo this another time. Can you see my slides?
Yes, Doc.
Okay, we're good?
Yep.
Okay, great. So I want to thank the Lions for organizing today and for inviting me to speak. Thank you, Dr. Zarbin, for putting the program together. I'm the third speaker of the day. I thought you've heard Dr. Turbin and Dr. Wagner mention OCT. We've had a very generous support from the Lions to the department with the new handheld OCT. So I thought this was a good opportunity to talk a little bit about the technology and how we use it. Specifically for me in glaucoma, it's part of the daily care of patients. This is not a research realm. It's a part of what we do every day. And really, OCT has changed the landscape in ophthalmology and the way we practice. A few words about the Lions. When I joined the faculty back in 2011, my first grant supporting the outreach program in telemedicine was from the Lions. That's the program that I work very closely with Dr. Ben Zerth, who I'm sure you know of and you've heard him speak in the past, where we do community screenings in Newark and all across New Jersey, and we also do some international work as well. And a lot of the technology that we use, including OCTs, and integrating all these technologies into protocols for screening for what we call vision-threatening diseases like glaucoma, diabetic retinopathy, macular degeneration, cataracts, and we screen individuals that have no insurance or that are underprivileged in soup kitchens, homeless populations in various parts of the state, and then we try to do that in real time and refer them back to the university whenever that is feasible, or to local support networks. And a lot of that work is possible because of the support of the Lions. OCT is a very technical subject, and those are my disclosures, but none of them are relevant to the talk I'm giving today. So optical coherence tomography, or OCT, has really changed ophthalmology. And this is not a new slide. It's older, but you can clearly see how OCT took over and it became, the #1 imaging technology really in ophthalmology, surpassed other techniques that we still use, but to a much lesser extent. And hand in hand with that came like an explosion in research with optical coherence tomography, as we understood better the technology and what it does to help clinicians diagnose and follow various diseases in the eye. And this is also not a new slide, and I'm sure the curve continues to go up. But to briefly tell you about OCT and to describe what it does, to kind of like trivialize it, it's basically, Dr. Wagner called it a biopsy with a light of the tissues in the eye. It's basically kind of like an ultrasound of the tissues in the eye using a light. And light, as you know, is made of different wavelengths, the red, blue, and green. The red having the longest wavelength, the blue having the shortest wavelength. And I have two images of the sky there to show that the one on the left, when the sky is blue, it's because the blue wavelength of light scatters the most, and it's the shortest wavelength. So during the day, the sky looks blue because all the blue light is scattering, and the eye catches the blue light the most. At sunset, when the rays of light have to go through the longest distance in the atmosphere, it's only the red wavelength, which is shown here, can penetrate all that atmosphere, and that's why the sky looks red early in the morning and at sunset. Can everyone see my my pointer, by the way?
Yes, we can.
Okay, very good. So the basic principle of OCT is very similar to what I just mentioned. It's basically a light that the computer shines into the eye, and then the different wavelengths reflect. Depending on the delay of these reflections, the software can put together an image of the retina. And just to give you some history, the early generation OCTs really relied on moving parts, like mechanical parts, like a rotating mirror that would bounce that reflected light into a sensor. And because of the limits of a mechanical rotation, those machines were only able to perform a certain number of images per second, which is labeled here as 400 A scans per second. And the resolution was not great. You can see that image there. You can tell that the retina resolution is not that good. As the technology evolved, like everything that relies on technology, we currently rely on what we call spectral domain OCT, which is much faster technology, better resolution, and you can literally see the individual layer of cells within the tissues. Shown here is the macula that also Dr. Wagner showed you an image of. So as these technologies become faster, the advantage is not just the resolution, it's also the fact that we could image the eye before any movements occur. Movements, it's kind of like taking a picture with your cell phone. If the handheld, if your phone moves, the image will, the picture will not be crisp. Same thing with OCT. When we can acquire these images very quickly, the quality of the images are superb and are clinically more useful. This is not research now. This is mainstream medicine. The current, for example, technologies that we have in the department are very fast OCTs that can acquire up to 100,000 scans per second and have a resolution of 3 to 5 microns. And that's why you can see those various layers and measure the thickness of these various layers, so you can follow different diseases like glaucoma, for example. This is an OCT of the optic nerve in a glaucoma patient, and the software will be able to measure all these thickness of nerve tissue, so we can follow over time and determine whether the patients are stable or they're worsening or they're progressing. Again, here, as the resolution improves, the definition of the tissue on the scans improves, so we're able to measure nerve tissue, for example, in the optic nerve, and follow these scans over time to determine whether patients are stable. So to take a step back and tell you a little bit about glaucoma, as you may know, glaucoma is damage to the nerve, to the optic nerve, which conducts the images to the brain from the eye. And the damage to the nerve tends to be irreversible, unfortunately, leading to loss of vision. And loss of vision ultimately leads to a degradation of quality of life. Those are just simulations of what patients see in various stages of the glaucoma. Glaucoma is a progressive disease, so if untreated, it almost invariably ends up in blindness. But even in the earlier stages, it could be like a checkered, like a chessboard type of vision, where certain parts of the field of vision are missing, which makes it very hard for patients to perform daily activities like reading the number on the bus on a moving target, or driving, for example, going down the stairs. All these trivial functions can become very challenging to glaucoma patients. And glaucoma is a tricky disease because it's a spectrum. It's painless, no pain. It's a genetic disease. Patients may not know that they have it for many years. And because it's painless, it gradually takes away the vision. And often patients do not recognize that they have it until a significant part of the field of vision has disappeared. In the early stages of the glaucoma, the peripheral vision is still intact. And that is the best time to initiate treatment, when the vision is still intact. And OCT is central in helping us identify those patients. Those are images from before the era of OCT, and they're taken 2 years apart. Those are old photographs of the optic nerve, top in color, bottom in what we call red free or black and white. And you can see that this part of the retina around the nerve changed color. And what that indicates is damage, the earliest sign of damage to the nerve fibers in the retina in glaucoma. Now, this patient at this stage had still an intact peripheral vision, but then 2 years after that, the patient started to show signs of visual field damage. And unfortunately, when patients start to manifest this visual field damage, they've already lost like a third of their nerve fibers in the back of the eye. So that's why in a disease like glaucoma, key is to identify those patients as early as possible. And that's what OCT allows us to do. In the past, we relied on pictures of the eye. Now we rely on OCT to make these identifications. Those are serial images of OCT of the nerve in a glaucoma patient. And the areas marked in red are areas of damage to the nerve fibers compared to a database of within the computer of patients of the same age. And you can see this patient was lost to follow-up, was not very adherent to treatment. And you can see that the disease is progressive, and now the top part of the nerve is starting to show some damage. But also note that although the OCT clearly shows deterioration, the fields are lagging behind, and they're not showing the damage to the field of vision until much later in the disease process. So, and that's the conundrum with the glaucoma. It is kind of like a puzzle where you need to put multiple pieces of information together to determine whether patients are stable or not. And to do that, we rely on examination in the office, eye pressure measurements, and on OCT and visual field testing. And it often arises, the question arises, which test is the best to detect glaucoma? And the short answer for that is it depends on the stage of the disease. As I mentioned, the disease is progressive, and this graph, the green line, shows progressive loss in patients where they're losing their retinal cells as the disease worsens. And in the early stages of the disease, which are critical to make the diagnosis when you can still preserve the function, OCT does best. As the disease progresses and a lot of nerve tissue is lost, then visual field testing, which we do in the office, becomes more important. So the value of OCT is to detect these changes over time, both to diagnose glaucoma as well as to diagnose worsening. And the technology has really drastically, significantly improved over the past, I would say, 10 years, but definitely the last 5 years. And in the department, in the last few years, we have these platforms that allow us to acquire information from different technologies like visual fields and OCTs and combine them and run these sophisticated statistical analysis. This is an analysis from a patient that shows serial OCTs over time, showing progression of disease And over here, you can see the progression of loss on the field. And these type of analyses help us determine when patients need more medications, lasers, or surgery in the operating room to lower their eye pressure and slow down the disease progression. But I always talk to residents about this and to students that technology will never replace the human element, us interacting with patients. And although technology have made the science of medicine a lot more accurate and allows us to do to detect pathology very early, it's still no substitute to human intelligence. We talk a lot about artificial intelligence these days, but all these technologies are fraught with artifacts and things that the clinician has to be aware of. This is, for example, a floater in the back of the eye. A lot of eyes have floaters. If the floater is big, it could block the light from the OCT and give you a picture and give you an abnormal scan. But this has to, of course, be interpreted within the clinical context. And that's why it's important that we marry these technologies with the clinical examination. Movements, as I mentioned, for example, blinking can cause artifacts on these scans. Dr. Wagner spoke about nearsighted or myopic eyes. Myopic eyes tend to have different appearance around the nerve, and these changes in the back of the eye can fool the software that can read scans as abnormal. When patients move, again, you get these artifacts on the scans. It's very hard for some patients to fix and maintain gaze while we're acquiring these scans, even for a few seconds. So all of these have to be taken into account. The software is great, but it still makes errors, and interpretation, just like with a CAT scan or an MRI, interpreting the results is key. And we can't simply rely on the software to generate a red or a green and to tell us whether this patient is normal or abnormal. This is an image, for example, from a patient with some retinal pathology, what we call an epiretinal membrane, which is a scar tissue on the surface of the retina. Again, fooling the software into measuring at the wrong layers in the retina, and the reading on the OCT shows an entirely normal scan, whereas this patient has glaucoma, for example. OCT, as I mentioned, has evolved over time. The newer machines not just have a better resolution and are quicker, they're able to image wider sections of the back of the eye at a high speed, and imaging large sections in the back of the eye, like the nerve and the macula, will allow us to better place those images on top of one another when we're trying to do longitudinal or long-term analysis. It centers images better than prior technologies, which helps us get better quality and more accurate scans. And it helps us image both the nerve and the retina at the same time in one section, which provides for better quality images. And basically, OCT, this technology and research in OCT, has taught us that the very early signs of glaucoma actually occur in the retina, not in the nerve. And now currently it's part of practice where we acquire these scans of the macula or the center of the retina to look for the earliest signs of glaucoma. And all these technologies, both from OCT and visual field testing, feed into these various platforms that allow us to do sophisticated analysis and determine whether patients are stable or they're worsening over time. This is an example of a patient that was clearly not on track, was not doing well, was slowly progressing. And then here we intervened with the medication, and you can see that the slope of the deterioration has improved. Still requires more work. This patient will likely need another intervention to flatten that slope. But prior to all these technologies, we often intervened little too late on these patients. So now with OCT and visual field testing being integrated, we're able to detect progression quicker and intervene in a more timely fashion. Now, going to handheld OCTs, which the Lions have donated this this brand new unit that we currently have that we could use on patients and in the operating room. Current technology with OCT relies on tabletop large machines, and we do know that not everyone can sit against an OCT, particularly patients, for example, with that are wheelchair bound, children in the operating room, as Dr. Zarbin mentioned. So a handheld OCT can make a big difference in clinical practice. And back in 2013, Dr. Zerth, with a team of medical students and myself, tested a handheld unit, but you could see it was pretty bulky, but it still helped us image patients in wheelchair. And these are images of the unit that the Lions donated to the department. And you can see the hardware is much smaller, so it's easier to navigate. When it's heavier, also there's less movement, so you get better quality images. It could be used in the operating room, like Dr. Zarbin mentioned. He used it recently on a patient. You can use it to image the back of the eye. This is, and unfortunately, children do get glaucoma, and we are the referral center for babies with glaucoma in New Jersey. So this technology will help us image children in the operating room to better document the extent of damage to the nerve, so we can follow them over time. You can also use this OCT to image the front part of the eye. These images are also from a baby with what we call Peters anomaly, which is an abnormality in the cornea and in the iris, which is the colored part of the eye. And these patients do get glaucoma as well. So portable OCT allows us to do all this work in a much better way for our patients. And I think this is my last slide, and I share this with the residents all the time. Technology is great, and it has helped us evolve in patient care tremendously over time, but it's not enough. You still will always need the human element, examining patients. This is an example of a patient that has a hemorrhage on the nerve that you can see here on the color photo. You can see the shadow of it actually on the OCT, but the software did not pick it up. It labeled this nerve as entirely normal. And we do know that in glaucoma, these splinter or tiny hemorrhages on the nerve usually indicate worsening of the disease. So again, no substitute for an exam and a face-to-face interaction with the patient. So we've talked about all these advances with OCT and the handheld OCT that was recently donated to the department. And I want you to know that we're grateful for all the support. I've received multiple grants from the Lions throughout my tenure. I think at least 4 or 5 grants, and that has helped me and the team of doctors that I work with promote all these research protocols and advance what we do and to help patients. So thank you again for having me today, and I'm happy to entertain any questions you may have. I think, Marco, you're muted.
Excuse me. Thank you, Albert. That was a comprehensive talk, and I actually learned quite a bit about modern glaucoma management. What causes the Durant's hemorrhages? I've never understood exactly. I mean, I know it's a sign of worsening glaucoma, but what makes it happen?
I wish I had a short answer. We really do not know. Some believe it is like an infarct in in the inner layers of the optic nerve head related to like abnormal blood flow in that watershed area in the optic nerve, but we really do not understand it fully.
So here's a crazy idea. I always thought that the deformation of the lamina cribrosa was part of a process of unexplained, but a process in which there's damage secondarily to the ganglion cell axons, and there's this idea of ischemia contributing to that process. So if there's ischemia generally in most places in the body, then there's increased VEGF production. And if there's increased VEGF production, then there's going to be breakdown of the blood-retinal barrier. And if that happens, then there's going to be hemorrhage. And so the area that's the most damaged would be the most ischemic with the most VEGF, and it would have the greatest propensity to show the bleeding. And I presume the bleeding is from the inner retinal capillaries. I mean, I don't know if that's been proven to be true or not. But I did wonder if it actually shows that glaucoma is in some fundamental way an ischemic disease
process. And that's the beauty of a retina specialist thinking about glaucoma from a retina perspective. Could very well be. I mean, OCT, particularly with enhanced depth imaging, EDI, there's a lot of literature on these defects in the lamina cribrosa, which is, and they've been imaged very nicely. And sometimes the hemorrhages occur in areas of the weakened, of the weakened part of the lamina, or in areas with what we used to think were pits in the optic nerve head, which are defects.
Here's a thought for which you can throw in the garbage if you want to. But we have OCTA. And if what I said is true, an earlier sign of glaucomatous damage is actually going to be abnormalities in the peripapillary OCTA. And if what I said is true, the areas that show the greatest damage are going to have the highest probability of demonstrating adrenal hemorrhage, and also the highest probability of demonstrating nerve fiber bundle defects. I almost can't believe people haven't studied that yet. But if they haven't, because talk about early marker, that would be way earlier than what we're talking about. I mean, based on what I've learned from you during the lecture. Anyway, it's just a thought that occurred to me.
Yeah. Thank you.
Well, I think that we have heard some really fantastic talks. I have to say that, even though this is what I do for a living, I learned a lot this morning from each of the speakers. And I want to thank each of you again for the time from your families and for taking the time to put together such excellent presentations. But I also want to, on behalf of the speakers and everyone in the department and our patients, I want to thank the Lions for everything you do. You sacrifice personally, and we appreciate it. And we try to acknowledge it in various ways inside the department, so that everyone knows, the people sitting down know, and we're here for you. If there's something we can do to help, please let us know. Mel and I often talk about screening, and the screening is something that was become modern, just like everything else you've heard today. When I started out, screening was a resident going with a direct ophthalmoscope, and not even doing dilated fundus exams. Now we have very sophisticated screening technology. We screen 19 down an hour with these technologies. We don't do it with a resident and a direct ophthalmoscope. We do it with a team of people with a lot of equipment. It requires planning and an appropriate location with electrical power, so we can run these diagnostic machines. But the result of this imposition of the pre-planning and the right location with electrical power is that we can do a very, very high-grade screen, and I think we can help people by doing it that way. And we do it in all different locations, churches, mosques, temples, Department of Justice, airport, military bases. We've done it everywhere. Dr. Zerth has led that effort. And if you give us warning, we're happy to incorporate that, any screening needs you have, into our process. So I want to thank you all very much, and I hope you all have a good morning and a good weekend. That effort. And if you give us warning, we're happy to incorporate that.
Well, I guess I'm going to be saying the thank you for the Lions.
So I want to thank you all.
We definitely want to thank all of the participants that were here today, especially our doctors who donated their time and their weekend to be able to present these programs to us. And we definitely hope that everybody's learned quite a bit about the new things that we've done and what Lions Eye Research has done to help these people do their jobs. We definitely want to also thank all the people who signed in. And it's been a great day to be able to present this program to everyone, both here in New Jersey, but it's also on YouTube and in other places. So we appreciate everybody signing in, and we look forward to another program in a year from now.
Present these programs to us. And we definitely hope that everybody's learned quite a bit about the new things that we've done